Eduardo Emanuele. I am a NASM certified personal trainer, also a student at Kaiser University Orlando campus. This video will consist of a participant going through a series of assessments, subjective assessments, which are Part Q, a health history questionnaire, and a general medical questionnaire. After compiling that information, we will do an objective assessment, which are divided into transitional and dynamic assessments. A transitional assessment is one that you don't change the base of support, and a dynamic assessment is one that you will change the base of support, such as a Davis test. In a transitional assessment, we will do overhead squat assessments, single leg squat assessment, star excursion assessment, and a rotational assessment. NASM subjective assessments include the Part Q, the general questionnaire, and the medical questionnaire. For the Part Q, my assigned client didn't answer yes to any of the questions. And for the medical questionnaire, she didn't answer yes to any of the medical questions. So questions that ask about if she takes any type of medicine, if she has any other conditions not mentioned in the Part Q. And for the general questionnaire is just for the trainer to get to know more the client. And for that, she answered that she's a teacher, she sits for prolonged periods of time, and that she wears heel shoes. Based on that information, one can suspect that that individual has tight hip flexors, tight gastrocnemius and soleus, and also that their cardiovascular fitness is not developed. My client, she is a 5'3" female, and she weighs about 130 pounds. So based on those numbers, one can tell that she is not overweight. In the anterior view, we can see that there's a side shift. The side shift is due to a tight or overactive sternocleidomastoid, also the upper trapezius, a levator scapula, and scalenes. All of them are active in the same side. For the underactive muscles, you have the sternocleidomastoid of the other side, levator scapula of the opposing side, and scalenes of the opposing side. Same as for upper trapezius, deep cervical stabilizers of the opposite sides are underactive. In the lateral view, we can see that the client has a slight lower cross syndrome. A lower cross syndrome is attributed to short muscles such as the gastrocnemius, soleus, hip flexor complex, adductors, latissimus dorsi, and erector spinae. The lengthened muscles in the lower cross syndrome are the anterior tibialis, posterior tibialis, glute max, glute medius, transverse abdominis, and internal oblique. In the posterior view, we can see that there's a left shoulder elevation. This is attributed to the tight sternocleidomastoid of the same side, levator scapula, scalenes, and upper trapezius of the same side. This is very similar to the anterior view tight muscles. Since those muscles are connected, this is the action that we can see. Potential underactive muscles are the sternocleidomastoid, levator scapula, scalenes, and upper trapezius of the opposite side. As a tester, you don't want to correct the participant's movement deficiencies when performing an assessment. The reason is because you want to preserve the client's movement as natural as possible. Also, whenever you correct a client during an assessment, this negatively affects the validity of the assessment. In the anterior view, the client is having a hard time maintaining a proper squat form. Even though she is not able to maintain a proper squat, as a tester, one can assess her movement dysfunctions. In the anterior view, we can see her feet flattens, and she shows an ability to keep her elbows extended. This is attributed to an overactive lateral gastrocnemius, biceps femoris, and tensor fasciae latae. The underactive muscles in this movement dysfunction will be anterior tibialis, posterior tibialis, medial gastrocnemius, and glute med. The inability to maintain the elbows extended is attributed to an overactive bicep brachii, latissimus dorsi, teres major, and pec major. The underactive muscles are the tricep brachii and rotator cuff muscles. In the lateral view, the client's knees are passing the toes. Her heels are lifting off the ground, and when observing the lumbopelvic hip complex, one can see that the lower back arches at the top position of the squat. If I were to correct her biomechanical dysfunction of her heels lifting off the ground and keeping her knees behind her toes, my theory is that there will be a case of excessive forward lean as a compensation. My explanation for this theory is that the muscles that are overactive in the excessive forward lean and the heels lifting off the ground all include similar overactive muscles. The overactive muscles are soleus, gastrocnemius, hip flexor complex, piriformis, abdominal complex. The underactive muscles are anterior tibialis, gluteus maximus, erector spinae, intrinsic core stabilizers. In the first repetition at the posterior view, we can see that her heels are lifting from the ground and her feet are flattening. These compensations were previously seen in the anterior and lateral views. Also, as she continues to perform the overhead squat, we can see an asymmetrical weight shift at her hips. This is due to an adductor complex in TFL, gastrocnemius, soleus, piriformis, bicep femoris, and gluteus medius, all of them being overactive. For the underactive muscles, we can see that the gluteus medius, anterior tibialis, and adductor complex are underactive. In the single leg squat, we can see on the right clip that the right knee moves valgus. This is due to an overactive adductor complex, bicep femoris, tensor fasciae latae, lateral gastrocnemius, and vastus lateralis. The underactive muscles are the medial hamstring, medial gastrocnemius, gluteus medius, and maximus. Also the VMO. Also, in both clips, we can see the lumbopelvic hip complex has a hip hiking compensation. This is due to an overactive quadratus lumborum, tensor fasciae latae, and gluteus minimus. Also an adductor complex and gluteus medius underactivity. The push-up assessment evaluates the function of the lumbopelvic hip complex and the scapular and cervical spine stabilizers. As the client continues to do the push-ups, we can see a forehead lean at the cervical spine. This is due to overactive upper trapezius, sternocleidomastoid, levator scapula. Also, the underactive muscles are the deep cervical flexors. The purpose of the STAR balance excursion test is to measure multiplanar balance and neuromuscular efficiency of the testing leg during closed chain functional movements. As a health and fitness professional, we should assess in which plane of motion the individual has the least amount of control. The individual has trouble maintaining balance in all three planes of motion while using both legs. This is due to overactivity in the gastrocnemius and soleus and weakness in the anterior tibialis and posterior tibialis. This is due because the anterior tibialis and posterior tibialis isometrically stabilize the ankle complex. And whenever they are weak, they are unable to do such actions. The upper extremity transitional assessments are used to determine any specific movement deficits in the shoulder complex. These assessments include the horizontal abduction test, rotation test, shoulder flexion test. Compensations that we will look for in the horizontal abduction test are if the shoulders elevate, if the shoulders are protracting, or if the elbows are flexing. For the rotation test, if shoulders elevate, if shoulders protract, or our hands far away from the wall. Whenever we're doing shoulder flexion, what we're looking for is if his shoulders are elevating, if the lower back is arching, and do the elbows flex. In the horizontal abduction test, we don't see any of the mentioned compensations, although we do see that the head translates forward. There are no clear evidence of why this could happen, but with the assessments done priorly, we could witness that the client's levator scapula sternocleidomastoid is tight. In the rotation test, we can see that clearly her shoulders protract when internally rotating. This is due to overactive pectoralis major, minor, and hypomobile posterior capsule. Also, the underactive muscles are rotator cuff, rhomboids, and middle to lower trap. In the shoulder flexion test, we can see that the lower back of the client arches. This is due to a tight or overactive erector spinae and pectoralis major. Also, we can see the same underactive muscles as in the prior compensation, which are the underactive rotator cuff, rhomboids, and middle to lower trap. In the Davis test, we can see that the subject is unable to maintain a proper plank position. This could be due to a weak intrinsic core stabilizing muscles. As you can see, the client's hips are elevated above the shoulder and head level. This is an improper plank position. After gathering all that information from the objective and subjective assessments, now we're going to compile a corrective exercise program. Such program will focus on inhibiting and lengthening overactive muscles, activating weak or underactive muscles, and integrating a functional movement. The first corrective exercise program will focus on inhibiting the gastrocnemius, soleus, bicep femoris, and tensor fasciae latae. Then it will focus on lengthening the same muscles. After that, it will activate the anterior tibialis, posterior tibialis, and glute medius. After doing that, we're going to add an integrative exercise that will entail a functional movement, such as a squat to overhead press. To inhibit the mentioned muscles, we're going to utilize self-myofascial release by the concept of foam rolling. Lengthening techniques will be done by static stretches of the same muscles, and then the activation techniques for anterior tibialis will be resisted or isometric dorsiflexion, and for posterior tibialis we will focus on plantar flexion and inversion isometric contractions. Such contractions could be held for about 15 seconds. The second corrective exercise program will focus on biomechanical dysfunctions in the upper body. Such dysfunctions were seen in the upper body transitional assessments, and also were seen in the overhead squat when the client was unable to maintain full extension of the shoulder joint. So the first action is to inhibit the pec major and lats. This is via foam rolling. Then after that, we're going to lengthen the latissimus dorsi, pec major, upper trapezius, and levator scapula. After incorporating those two techniques, we're now going to activate the rhomboids and lower trapezius. This could be done by doing a cobra with shoulders retraction, like this, like so. And then we can incorporate or integrate a row to W. Then we're going to integrate a standing row test. So this will activate the core musculature and also maintain proper alignment in the shoulder joint. The third corrective exercise will focus on fixing any biomechanical dysfunctions that we're seeing repeatedly after different assessments. This biomechanical dysfunctions focus on tight gastrocnemius, tight hip flexor, and tight lats and TFL. Those were the muscles that were mostly seen. Again, the muscles that were mostly seen were the gastrocnemius, hip flexor, latissimus dorsi, and tensor fasciae latae. Because of that, what we're going to do is inhibit those mentioned muscles via, again, foam rolling, lengthening the same muscles via static stretches. And this one, what I want to do for this third corrective exercise program is doing positional isometrics for the anterior tibialis, glute med, lower and mid trap, and adductor complex. In the integration technique, what I want to focus is on a low intensity deadlift. This is due because the underactive muscles most of them are located in the posterior chain. So a deadlift will focus on all those pulling muscles. Thank you very much. Have a good night.